So we come back to this. So I have a few slides, Jody. We're right on time, 7:25. Normally, we always think about these talks being about 30 minutes to, get people excited. So see what you're doing. And I'm going to have Dr. Mead, as I go through some of the slides, say a few words. Paola, you ready to rock and roll?
Yes, sir.
Go for it.
Good morning, everybody. Welcome, Dr. Leonardo. We're very excited to have you here with us today, this morning. Dr. Q, can you go to the next one, please? So just as a background for Dr. Leonardo, she graduated as a Bachelor for Liberal Arts. She graduated summa cum laude from Duke University in Pittsburgh. She then went to Medical University, to the Medical College of Pennsylvania and Hahnemann University. She then did general surgery at Allegheny in Pittsburgh. She then went to do neurosurgery in Buffalo, where she met Dr. Tuck. And they're very good friends. Dr. Tuck sends you a very warm regard and hug. And then in 2008, she did an intracranial and skull-based neuroendoscopy fellowship in the Netherlands. She then came back to the US as a professor in Buffalo, and then she moved in 2018 as a program director at Allegheny. And right now she's also the program director and an associate professor in the Drexel University College of Medicine. This is some of her contributions to the literature. She has a lot of papers and a very high index. If you want to go to the next one. And these are some of the papers that Dr. Leonardo has published, and she's going to talk to us today about another paper that she has been working on for a lot of time. We had the opportunity to talk to her a couple of months ago in the Walter Grant, and we look forward to having her back next year. This is the plaque that we're sending you, Dr. Leonardo, from the lecture series to thank you for your time this morning and for being here with us today.
And Jody,
sorry,
I was just going to say, I was just at a personal level. It is a pleasure to see you, doing with the Walter Grant what you guys have been able to do, and every year, despite of many issues with the pandemic, just seeing you guys get together and see the involvement, the building bridges between the different institutions, continue that tradition is a great pleasure. And actually, you should know that your lecture was requested, not only of course by the faculty, but all the fellows who got a chance to meet you, a lot of them who you saw some of their work right here, they requested to have you. And it's a great honor when people not only request, they demand, they say, we have to have Dr. Leonardo. And it is beautiful because that tells you the impact that you're having on people around you, and they see your work and see your energy, your enthusiasm. Go ahead, wrap it up, Paola, and then we'll let Jody continue.
So Dr. Leonardo is going to give us a talk that is titled The PARS Paper, Perceptions versus Misconceptions of Training the Modern Neurosurgeon. Welcome, Dr. Leonardo.
Thank you.
Beautiful. I'm going to stop this sharing so that way you can share this, Jody. Just great to have you.
Thank you so much for having me. And let me just make sure, can everybody hear me okay?
Yes.
You can see my slides?
Yes.
Okay. Well, special thank you, Dr. Q, for everything and for having me today. It's really an honor to be here. I can certainly say from the bottom of my heart that I've personally enjoyed the collaboration we've had with the Mayo over the past, oh my gosh, I don't even know how many years it's been, but you have enabled us to carry on our legacy of love and teaching. And again, I'm so happy to be here. And, listening to everything this morning, it really is earth shattering, and it blows you away in terms of seeing how much everybody at Mayo is doing around the world. What a platform. And, I was thinking of the talk I was giving, and I thought, well, I hope people are interested in this. I was going to talk about endoscopic neurosurgery, but it's so appropriate. And I think particularly in an institution such as yours, I'm really hoping that everybody will take something away from this. So moving on, disclosures. I am a consultant to Esculap, which is a company with intracranial endoscopy, and I do receive monetary compensation for time spent in product development, as well as professional and patient education. But most importantly, a personal disclosure. So the topic of this presentation came to mind probably almost 5 years ago. We had a combined orthopedic ran rounds, and a speaker came from the outside, and he talked to the neurosurgery and the orthopedic departments about faculty development and training, future residents. And at that presentation was all of my residents in neurosurgery and the faculty. And I thought it was one of the best presentations I've ever heard in terms of, what you need to do from a faculty perspective. But I was shocked that afterwards, the residents were horrified. They were upset, they were agitated, they felt that they were generalized. And really, I kind of walked away with that thinking, oh my gosh, how could I get so much out of that? And how could they just be really, turned off by that? And so fast forward to now, giving this presentation, I want to be very, very careful and very, very sensitive that I don't offend anybody, that I don't offend any students, any residents, any faculty members by giving this presentation, because, ultimately, when I look back on my career, and, surgery is wonderful and patients are wonderful, but I've gotten, so much fulfillment for being a part of these young students and trainees' lives. So I really hope I do not offend anybody. So moving on to my content warning sign, the terminology and generalizations that I use here, not meant to offend anyone. Rather, they serve as broad descriptions and oversimplification of various traits or characteristics that are used by historians to categorize and to classify generational differences. So I'm not a historian, obviously. Am I an educator? Well, I think by default, I've never received formal training in education. It's kind of learn on the fly. But this is kind of what I've put together. So I asked that everybody listen with an open mind, and hopefully this will encourage thought and potentially discussion. And consent has been obtained to use the photographs and videos in this presentation. So this all started with the PARS. And for those of you who know me, I do more cranial surgery than spinal surgery. And I have always been fascinated with the PARS because I don't think people really, there's not a great definition of it. And it's really interesting. It's a great pimping question for the medical students because it's a really hard anatomic structure to define. So I've always talked about this with my residents, and I always encourage them, and I've assigned them one at a time. Somebody needs to write like a historical, a historical kind of publication of where the term PARS came, what it means in terms of surgery. And to be honest, year after year after year, nobody followed through, which isn't surprising because sometimes we take on more than we can chew. And as I continued, and just through time asking people what the PARS are, these are some of the descriptions that I got from students, even residents: the bone between the two pedicles, the stuff between the facets. Like, there needs to be a much more defined definition. And so one day, Dorian came. Dorian, this is pictures from 2016. This is when Dorian was a PGY3. And I could tell by meeting Dorian that he had, he usually followed through. He was very attentive. And I thought, you know what, he's going to be the person that's actually going to take this PARS paper home to the finish line. So I approached him, I asked him, and he looked at me and he said, "Oh, Dr. Leonardo, that sounds like a great idea." He's like, "Let me get back to you." So fast forward 2-3 days later, he texts me, he goes, "Can I talk to you?" And I was super excited because I thought, oh my gosh, he is going to do this paper. And he met me outside the intensive care unit. He said, "Listen, I was thinking about what you were asking me to do, and I just want you to know I'm not interested." And I just, I couldn't believe it. And I'll be honest with you, I was kind of agitated. Like, really? I asked you to write this paper. I gave you all the background and you decided, you made an intellectual, purposeful decision not to do it. So this is where this presentation comes from. So I was left by myself again with the PARS. So looking back, my training, and I think this is one of the reasons I was so put off, is that, back in the day, and I'm certain, that many of the faculty that are listening probably can agree with me. But when you were asked to do something, you did it. It was a structural hierarchy. And this goes back to my chair, which was Dr. Levy at University of Buffalo. He always talked about the message to Garcia. And so when you read the message, to Garcia. It's an essay that was published back in 1899, and I think it still is very pertinent in modern day times, but essentially told the story of it was before the Spanish-American War, where President McKinley had to deliver a message to one of the leaders of the insurgency in Cuba. And so essentially, he needed somebody to go into the mountains and find Garcia and deliver this message. And one of his advisors in the room stood up and said, well, you know, I have just the person. And this person was Lieutenant Andrew Rowan. He's the person that will do it. And there's actually 2 movies about this, and you should watch them. They're real quick on YouTube. But essentially, when President McKinley asked Lieutenant Rowan to deliver this letter, he looked at him, he took the letter, he said yes, and he walked away. He didn't ask questions. He didn't ask what the temperature was in Cuba. He didn't ask how specifically he's going to get there, how he's going to pay for it. He just simply did it. So this essay, you know, it was written about individual initiative, and it was written about being conscientious with your work. And I think that's something that everybody can take, you know, no matter what generation you are. But kind of zooming out, when you look at the differences between, you know, through time and through residence and through training, you know, you want to pay attention to generational diversity. So generational diversity is a term which describes shared perspectives and experiences among individuals born within boundaries of time. So if you look on the right here, and this was published by Pew Research Center, this is just essentially a summary of the different generations. So starting at the bottom, you can see the silent generation, 1920s to 1945s, and none of these numbers are hardcore, there's a range. Baby boomers, 1946, 1964. Generation X, which is where I come from, 1965 to 1980, the Millennial Generation, 1981 to 96, and then the future generation, which is Generation Z. And what's really important when you look at this, this Millennial Generation, 81 to 96, essentially compromises 40% of the workforce back in 2020, but in 2025 will compromise about 75% of it. So right now in the workforce, for the bulk, it's the millennials that are with us. So zooming out and looking at this again on a larger perspective, you can see the average number of the population in the United States, Generation X, the millennials, and Generation Z. And the one other thing that you can look up by looking at this chart, and I know it's tiny, but this is important, is when you look at the generations and the generational diversity that comes from the generations, you see that there's 3 main influencing factors that fall into this. So number 1 is the family values and situations, parental styles. Number 2 is the global events, the history. And number 3 is the communication media and the social trends. And so all 3 of these play into the values and the workforce values that generation is summarized by the historians as having. When you look at the family values and situations, this is kind of interesting because, and there's a term called parental pendulum, where a generation reflects on how they were raised and develops parenting strategies in response. So the way the years go by, a person that was born in the generation, so such as the baby boomers, when they grow up, they're going to be parents of the millennials. And so in the baby boomers, we see that the baby boomer parents were characterized, at least historically, as the helicopter parents. And they're the ones that raised the millennials. And I don't like this term, but this is a historical term, the trophy generation. So you have the helicopter parents that are hovering, which breeds the trophy generation, the millennials. And then you have my generation, Generation X, where we had a lot of divorce and a lot of single parenting, and we were called latchkey children. And so latchkey children, when we grow up, we're the parents of Generation Z. And it's very interesting, you know, the more reading you do on this, Generation Z, these guys are raised, these children are raised with co-parenting and coaching. Their parents aren't necessarily their friends, but are in a kind of model of more as a coach. And the other thing I want to point out is just in terms of global events, it's going to be really interesting in the future what happens with Generation Z, giving all the school shootings, safetyism. So it should be interesting to see what happens. And from a communication perspective, the smartphone. I think a lot of this happens because of the smartphone, and that contributes to the general diversity. So looking through, you have general diversity within the world, and you also have general diversity within medicine and neurosurgery. And this is important just because if I wanted to go back within my personal experience and kind of point out a few things that have affected everyone. So I was trained by my mentor, Dr. Walter Grant. So he was one of the silent generations, and he was trained during the day where they were actually residents. They lived in the hospital. He told me, he always called me Wendy, but he would tell me, Wendy, I'd pack my bag and I'd go to work for a week. Maybe I'd come home for a few hours and I'd go right back. Well, those were different times. I was trained under my program director, Dr. Kevin Gibbons at University of Buffalo. And at that time, when I came on as a resident, so this is me as a PGY1, I show up in Buffalo and I could tell something had happened going from my surgical intern year in Pittsburgh to Buffalo. So in 2003, what does everyone think happened? And I'll be curious if anybody knows this. And here's a little hint. Does anybody know who this is? Anybody? So this is
Libby Zion.
Yes, absolutely. This is Libby Zion. And so for those of you who don't know who Libby Zion is Libby Zion was an 18-year-old who actually went to the hospital in New York. It was in New York, at that time it was New York Hospital, for a little bit of kind of altered mental status. And long story short, while she was in the hospital, she was cared for by PGY1, PGY2, and obviously they're attending. And she came in a little bit confused and then developed just shaky like movements, for which she was given Demerol. She previously, though, was on an antidepressant. And so what subsequently happened is she developed serotonin syndrome. Then she went into more convulsions. She became very agitated. They restrained her. And then before long, her temperature went up to 107. And then she suffered cardiac arrest, died. And then the family was called by the interns that the daughter, who was admitted earlier that day, died. So you can see here, this was published in Vanity Fair back in 1988. This is Sidney Zion. This is Libby Zion's father, who was an attorney. And he also was a New York Times, not an editor, but New York Times contributor. And so this got public attention very quickly. So Libby Zion died in 1984. There was a very large New York State investigation in 1986, followed by, in 1989, the Bell Commission was put together. And the Bell Commission was put together by Bertram Bell, who was a physician at Albert Einstein in New York, who was very involved in publicly criticized medicine at the time in terms of the lack of supervision in terms of training residents. And so with the Bell Commission, New York State passed the department section 405, which was Libby Zion law. So essentially in 1989, all New York State hospitals who had residents working, the residents were all mandated to work an 80-hour work week and no more than 24 hours in a day. So that was in 1989. And so only a few years later, 4 years later, in 2003, the ACGME, which is the Accreditation Council for Graduate Medical Education in the United States, took this up as well. And they enforced the 80-hour work week for all trainees in the country. So going back to 2003, when I got to Buffalo, at that point it was passed in 1989, but nobody was following it. It didn't take, it was the elephant in the room. We talked about it every now and then. Gibby would, Dr. Gibbons, we belovedly called him Gibby. Gibby would talk about it every now and then, but really didn't follow it. And then as time went on and through my professional development, I became program director at Buffalo and then came to Allegheny and became program director here. And on above me on the picture is Dr. Alexander Yu, who is my associate program director, my current colleague. So he and I are now training the residents, which are here. And it's very interesting when you look at the change that at least you can see kind of in this microcosm of neurosurgery and medicine, which was brought forth by Libby Zion. So currently in academia, you can see that the residents completing their training, for the most part, come from the Millennial Generation. And these guys are probably going to stick for a while because, as you can see from our PGY1s down here, And, I don't know what you think, Dr. Q, and Dr. Chaitanya thinks, but, a lot of the residents now take gap years, have years for research. And so I think the millennial generation is going to stay with us a little bit longer before the introduction of Generation Z. But our millennial generation are taught by myself, which are faculty from Generation X, and then faculty, as well from the baby boomers. And so what happens when you have faculty from two different generations that are teaching, a brand new generation? Well, sometimes it can get a little crazy. So when you look at this table, which compares the generational characteristics, you can see that the millennials in the brown on the right side of the screen, in terms of their attributes, they're hopeful, they need structure, they often rewrite the rules, kind of like Dorian did, informal, team-based, and meaningful work. And when I read meaningful work, I thought immediately, wonder if that's why Dorian didn't write the PARS paper. Was that because it wasn't meaningful enough for him? But you can see where I started thinking about all of this. So now we're going to get a little bit into the weeds here, but this is just a quote to introduce from George Orwell. Every generation imagines itself to be more intelligent than the one that went before it and wiser than the one that comes after it. So I just pose this question to everyone. How do you perceive what's thought of as traditional training? And just think in your mind the different terms that would come. And I gave this talk to my residents, and one of them shouted out, horrific, horrifying. But I would beg to differ. I think it was hierarchical, it was demanding, it was very rigid, extraordinarily self-sacrificing, very impersonal. It was very heartwarming to see the love, that you guys have in your department, and sharing the baby pictures and the wedding pictures. It wasn't like that, 15, 20 years ago. But, and again, I don't, content warning, because a lot of this is oversimplifications. And often a lot of this too is, in neurosurgery and neurology, I think we do have the cream of the crop, and we have people that really have worked hard. And so these generational summaries may not be able to be applied to people in our group. But how do you perceive modern day learners? So these are some things that could come up. Entitled, really? Self-centered, disorganized, driven by purpose and meaning, confident, disrespectful. So let's look at this a little bit more. So when you look at the attributes of millennials, this is what you see. High levels of confidence and optimism, team-based leadership style. I saw that this morning. Highly collaborative, seeking team instead of personal success, characterized as needing structure, tendency to rewrite rules, and formal view of authority, and feel rewarded when they create meaningful and purposeful work. Hence Dorian in the PARS paper. So you can see learners of today, we've had a different experience than the faculty may have had. Learners of today, they have different values, they have different expectations, and they have different ethos. Why? Because they're a part of a different generation. We would expect them to have this. But the learners of today have caught the attention of academia as they are challenging the tradition of medicine that was formerly steeped in hierarchy and very, very structural. So as a result, with learners of today versus faculty, you can see where conflict, misunderstanding, agitation can result, leading to a breakdown of relationships, compromising the educational structure. So I flash back to how I felt, when Dorian told me, that's it, I am not going to, as a PGY3, I'm not going to write your PARS paper. So faculty of today, in response, we can't ignore the generational differences. You saw the numbers. This is not going to change. And we have to understand the values, the ethos, the expectations of the learners in order to work effectively. But most importantly, and I think this is, if anybody takes anything from this talk, we must examine our perceptions of the modern day learner and ask, are these perceptions accurate, or are these perceptions misconceptions? So looking at, this is an article published in 2018 in JAMA, and it talked about the myth versus the reality in terms of training millennials. And so just to give a few examples, one millennial myth is that they're impatient. Well, are they? Or are they used to rapidly, filtrating information and being able to act upon it efficiently? Entitled versus motivated. They don't view social distinctions as we may have in the past, but they're very autonomous, and they'll get to the core of what they're looking for on their own. They may not use the latter, but they'll get there because they're motivated, not necessarily because they're entitled. And this is one of my favorites: lazy versus balance. So I'm going to be honest with you. When Dorian told me, I think I'm gonna have to go to counseling for my encounter with Dorian. But when Dorian told me he wasn't gonna write the paper, I thought, oh my gosh, he is so lazy. He is so lazy. But really, I think he probably wasn't really lazy. It was purpose over process. So how to best train modern day neurosurgical residents, as I tie this up, I think what's important is you need to restructure your perception of mentoring, and you need to tailor your approach to the learner's attributes, embrace a new take on traditional surgical competencies, which we'll talk about briefly. Mentorships, I think one of the most important things in life is to find a good mentor. Because it's a gift that keeps on giving. And what's really interesting about being a mentor and being a mentee is you don't just find one, it's a two-way street. You have to find someone, and they have to want to commit and to give time to you. But if you can find somebody that engages with you, it could be one of the most beautiful experiences. When you look at mentoring versus the old way, so this was a chair that Dr. Grant had in his office, and I would sit on this chair for hours, and he would pontificate and talk to me about all sorts of intracranial endoscopy and projects. And, at this point in time, those relationships really take a different form. And often you'll see, in terms of an academic institution, there's many different opportunities for micro-mentoring. So micro-mentoring is essentially 1 to 2 minute conversations, rapid thumbs up, thumbs down, yes, no. And with micro-mentoring, you can build these relationships over years. And I think one of the challenges for faculty is, when a resident pops in to ask you a question, you might say, okay, they didn't make an appointment, this is an interruption. Well, you know what, change your perspective, keep your door open, take advantage of the opportunity when they're scrubbing with you and ask you a question. Take advantage. I always tell them, I'm flying around the hospital, 50 million things to do. I always say, come walk with me. And we have a beautiful facility at AGH. My hospital where I work was built in 1887. And we have a brilliant modern day expansion. This place is really an incredible atrium with a coffee bar. And I'll say, come on, walk with me, and we'll go get coffee. And it's just those 2-minute walks, which really, I think, give you a nice platform to talk. Reverse mentoring. This is one of my favorite with the residents. You can see all these modern day apps on your phone. I really didn't know many of them, but allowing the residents to teach you something as faculty really builds a bond with the residents. This is one of my chief residents who I honestly, fantastic person. Drilling a hole for an ETV. I always tell them, drill the burr hole between the size of a nickel and a quarter. I get in the surgery and he drills a burr hole that's the size of a dime. Like it barely even fits the endoscope. And I said, Brandon, we talked about, nickel to a quarter. And he looked at me, he goes, well, Dr. Leonardo, I don't carry any currency anymore. I just know about Bitcoins. And so you can see this millennial generation. It is funny, and you got to embrace it, and you gotta laugh. So I got all the different coins and put them in his pocket one day, and I told him, study them. Mentoring teams, get groups of people together to mentor. And what this does is it allows for cognitive diversity and the power, of group thinking. So this is one way that we can really embrace millennial thinking and educate. And just a few comments here, and this was published in 2018, the Annals of Surgery. The millennials are here and they expect more from their surgical educators. And this is important because it teaches us that we need to tailor our approaches to the attributes of the millennials. So be positive, present the negatives as opportunities for improvement, not just come in and tell people why they need to improve. Invite them to join you, see firsthand what you do. Avoid pimping. And this is my favorite, and I think this is one that I've been personally most challenged by, is you need to abandon the concept that this is how it's always been done. It's time to change. It's time to move into the next millennium. In order to gain competency in a surgical domain, you need knowledge, you need skills, and you need attitude. And knowledge can come from many different means. YouTube videos, and you guys did such, beautiful illustrations of the ABNS cases and the different videos. All of those are phenomenal learning experiences that might not have been available when the faculty were learning. And this form of blended learning is really can keep it interesting and keep everybody engaged. And designing a curriculum, and for the program directors across the country, this is tough because you have a 7-year training period of different levels that you have to probably use these academic hours to incorporate and to include everyone. So designing this curriculum to get people from knowledge to actually performance. And one thing I just want to say real quick is getting to performance from the level of competence. Competence is what a physician is capable of doing, as demonstrated in an educational setting, but performance is what a physician actually does in practice. And that's attitude that gets you from competence to performance. And so when you're learning a skill, you want to incorporate all this blended learning with online videos. Back in the philosophy of William Halstead, see one, do one, teach one. You want to show the learner how, you want to tell the learner what you did, you want to ask the learner to tell you how, and have the learner show you. And we do this, and you guys do this because I've seen your beautiful simulation lab in the past. All of these operative experiences where they can practice in a group and bounce ideas. We do the simulation, and this is my partner Alex, who's taken a resident through a subarachnoid hemorrhage rupture, and you can see this is so much fun, and it does build a ton of camaraderie. And my partner is really quiet, but he lets loose on these, and he pretends that the aneurysm ruptures and the PGY1 is, you can see his heart rate goes up, and it's just like a great bonding session that everybody has in the spirit of education and attitude. These small group sessions where residents can teach each other under faculty development and build and talk is one of the best ways that you can really change the attitude and get these residents from a competence to a performance. And before I close up, this is my PGY5, and he's somebody, and I call him in my mind, he's my resident academic champion. Reflection cements the importance of the meaning and the purpose of what is learned in the group session. If you have a resident that's very mature and professional and articulate, these guys really help because they reflect, and through their reflection, everybody grabs onto it. They become a part of the discussion. So facilitating the residents that show us what we need to do and what we need to learn. So in summary, generational diversity happens, change is necessary. And to the learners, for us, perceptions, misconceptions goes both ways. You guys got to look at us, and you guys got to be patient with us, because we too, just like you, we're learning and we're growing. And to the faculty, practice your modern mentoring and practice tailoring your approach to the attributes of those that we teach. And let it go. Let go. This is how we used to do things. It's time to start afresh. It's time to start, anew. And to the PARS structure that I probably will never publish a paper about, I thank you. And Dorian just to close this up. Can you guys hear this?
So I just wanted to ask you a question, and I apologize for bringing this up again. But can you just tell me one more time why you chose not to write the PARS paper?
Forced laugh.
The PARS is the vital part of, I think, the neurosurgical lexicon. But at some point, you start becoming overcommitted to things, and projects have to go out to the wayside, and instead of having them wither away and just sort of take their time and just fade away into the darkness, sometimes it's better to have a clean break that you can find someone else to take over.
So why did you break away from the PARS paper and not the other papers?
I was frustrated with my own lack of vision for it. I didn't know where I was going to take it. So I think someone else will do a better job with it.
Is it because it didn't serve your purpose?
I mean, I definitely had a side hobby of historical interests, but at some point you really have to focus in on the things that are important for my career, which is functional neurosurgery.
And not the PARS.
And not the PARS.
So I finally was able to get to the bottom of it. It didn't suit his purpose, and that fits, and that makes sense. And he's an excellent, phenomenal resident, and I'm so happy I got to experience the PARS saga with him. just looking forward real quick, Generation Z is coming soon. So maybe in 10 years, I'll circle back and give some thoughts about Generation Z. But I just want to thank you, everybody, again, for having me. It's a pleasure to work with everyone. And it's just outstanding to see all that you've accomplished at the Mayo Clinic, Florida. Thank you.
Dr. Leonardo, that was an amazing talk. You can see the chat was blowing up with a lot of comments. I put a note, you know, when I finished my training in 2005, and used to be about hiring people. You just hire people and didn't have to worry. Mitch Berger didn't have to worry about a single thing. He just hired people and everybody would sort it out. And now it's about building teams, and building a team is what you saw that Chris was doing when he was fishing, making sure that people understand who we are. And I got to tell you, I learned from this generation because you and I train in a different generation. You're right. Back then, if Mitch said, write this paper, it was not, I mean, it was just, it would be done. But what I learned from this generation that we're not training is that it's okay to say no. Last week, I had a good friend of mine that needed me to do something. And I was there in the surgeon's lounge. And for the first time, I flat out say, sorry, I can't do this. And it was something related to work. And it was something simple, but I realized that it had no meaning to me. And I was already overcommitted, which is what your resident did. For the first time, you know, in my 5 decades of life, I done that because I'm learning from this generation that is teaching us. I open it for questions right now because I think there's a lot of stuff. I'm going to start with Dr. Fox, who also, he and I, we had a lot of discussions. First, the message to Garcia. Chris, you want to comment on that?
Sure. Dr. Leonardo, thank you so much. That was very interesting and thought-provoking, and really appreciate your insights. But ironic, you know, we showed pictures of my boat. The name of my boat is Message to Garcia.
Is it?
It is, yeah. So we're the exact same age. I'm also a bicentennial baby, and I'm sure we were exposed to many of the same things. I was also in the Navy. So I had a Navy scholarship. My first neurosurgery job was in the Navy, and that's a very traditional teaching because Lieutenant Rowan, of course, was you know, a Navy lieutenant who was tasked with taking the message to Garcia. So for the better part of 120 years, junior officers have been tasked with taking the message to Garcia. But interestingly, and kind of in parallel with your talk, recently, a number of midshipmen at the Naval Academy, where you think that hierarchy reigns supreme, have actually started complaining that the message to Garcia does not hold true in today's society, and they should be encouraged to ask questions and you know, not just kind of get the job done without asking them. So my own personal thoughts is I think there's a balance in America, you know, and everywhere, human nature, the pendulum never stops in the middle. Right. And we can all learn from each other, new methods, new ways of doing things. I love that you said, you know, we should get away from this is the way it's always been done, because I agree with that. But there is some part of surgery, I hate to say it, but it has to be the way it's always been done because there's somebody's mom, dad, brother, sister, spouse under the drapes. And I think there's a little bit of a danger in today's surgical training of forgetting that a little bit, because if we want to do things our own way, that does sometimes put patients at risk. So there has to be a balance of the old and the new. And I just hope that, you know, we have to look at this from a 360-degree perspective. That means trainees have to also learn from us that it's not always just their way, because we know the ways that are safest for our patients. You know, hopefully in that case, the dime-sized burr hole didn't cause any problems, but you know, there's certain things that just, you know, you have to walk first. You can't start off sprinting. But thank you so much. I really appreciate your talk.
Oh, thank you. Thank you so much.
And Jody, as we continue, if anybody has a question, please raise your hand so I can see you. You pop up in my camera. But I was thinking about what Chris just said right now, i.e. the checklist manifesto. All right, it took one's paper and the work, airline companies, the operating room. We now encourage people to speak up, anybody in the operating room, because we realized that the reason why airplanes were going down is because people were afraid of authority, right? And we cannot tolerate that because, as Chris said, we have lives in our hands, and that doesn't mean that we're right all the time. We may actually be in a rabbit hole and we don't even realize it. So encouraging people, that's actually a nice hybrid combination of things. On the other hand, is the ability to get proximal and distal control. The principles of surgery, they have not changed. Those principles are still the same, and they're going to be the same as long as we continue to do principle understanding physiology, understanding anatomy, and so on and so forth. So it's a combination of both. I see Ruchika right here, who's one of our visiting students from India, very active around the world.
Hello.
And I asked that question, will these principles apply to Latin America, Asia, Africa, Europe? You know, the generations. And I'm asking that question because at the same time, you see, I have students from all over the world. I'm going to challenge them to help me understand that, because I do really work in this international platform and I need to understand this a little bit better. Ruchika, go ahead, please.
So I think I can answer that question for India. In India, well, I think it's we practice old medicine, where we do what the professor says, and that's how it is, which is why it was such a big culture shock when I came to America and I was like, oh, you can do what you want for a little bit. Dr. Leonardo, thank you so much for the talk. Do you think that our behavior stems out of the fact that we're impatient? Because I feel that. I feel like I want to know now. I want to know everything now. I want to be the best now. I want to, maybe something like that.
I think
And how do we control it?
Yeah, I think it's a combination of different things. Honestly, I watched a movie with my niece. My niece is 9 years old over the holidays, and I was horrified. Don't tell my sister I said this, but I was horrified because Carly would watch the movie, and in parts that she never saw the movie before. She had no idea what was going on, but she could sense that she didn't want to watch this part, so she'd fast forward it. And I was like, Carly, I'm watching it. And she just kept, oh no, it's not important. Next part. That was what she did. And I thought, oh my God, she's Generation Z. And I thought, oh my gosh, we are in such big trouble. So the reason that I brought that up I do think that the smartphones, the social media, it has made kind of us as a society be less attentive, and with less attentive, you get the sense that people are impatient. So I think I do think that some of this is true in terms of, the societal trends do affect what happens. So do I think that your generation is impatient? Not necessarily. I think you're probably engaged, and I think you're probably anxious, and I think you're probably excited to get things done. So it depends on how you perceive it. But Generation Z, I don't know what we're gonna do with this next one.
And of course, Jody, to augment this level of complexity, the fact that they're communicating in a different way. Snapchat, TikTok. I'm going to ask you a question. Do you have a TikTok account?
My niece made me one, and I deleted it because I was getting sucked in, because I would watch it. But it was only because
yes.
One.
But it is important that we understand, because I just created my TikTok account thanks to Manuela here, Alex, and Paola. And I put up, and I actually last night I put my first video all by myself. I made like tons of mistakes, and Manuela was texting me last night from wherever she is in the world. But it is important for us to understand how they communicate. This is why we give the updates in social media, because the world is changing, whether we like it or not. And you're in your late 40s, early 50s, you still have 20, 30 years of life. And if we don't understand this, it's not going to allow us to communicate better and provide better patient care for a future generation. So I applaud you for doing this. I got two more questions right here, and then I want to get you to the residents to talk to them. Sharia and then JP. Go for it, Sharia, please.
Hi, Dr. Jody. I thought what you said today was so relevant because I came from India too, and practicing as a physician in India and working here at Duke. I work at Duke as a postdoctoral fellow in the Department of Neurosurgery. And I always thought it was so much easier to talk to my PI, who was way younger than the entire department. And I always went back and told my mom, see, he's so much easier to talk to and say no to. And he always understands and he makes fun out of the situation. And I think it's so important for the learning process. So I completely resonate with what you say. And I think my entire department should be watching this. It's so important to have this conversation. That's just my comment.
Oh, thank you.
Yeah.
Beautiful, beautiful. And by the way, Jody, Sharia is also very involved in Mission Brain around the world. They have different interests. They want to change the world. They're no longer just a region where we're working. They are participants. She's actually starting chapters in Africa. She's got 5 more chapters that she's been texting me that they're doing around the world. So they have a complete, because they're communicating. Their platform is global. It's no longer, we used to go out and play marbles or play, you know, little things like that. And our platform was this. Their platform is global nowadays. It's a completely different way of thinking. JP, please.
Dr. Leonardo, congratulations for the amazing talk. I have to say, I'm from 1985, so I think I'm a millennial. So, but I always kind of see myself as an old soul. So I kind of have an internal fight about where I fit in this model. But I have to say myself, for a reason or another, I have adapted to, even when watching a movie, got a cell phone, my computer in my lap, tried to do 4 things at the same time. And I realized that, at least myself, I fail big time when I try to do that. I realized that I do any of those things, but still it's a generational thing that we try to do. So I have to say that your talk today, being fully honest here, was one of the few talks that I was fully committed watching and listening to your talk. So congratulations for that. And I think that's probably true for many of us, because you were very successful in achieving a goal of getting our attention, I think, of everybody, in properly communicating a topic that speaks to all of us. So congratulations on that. And I think that's where we fail big time. I think that the issue of communication is one that we all have to learn a lot, and how to better communicate with each other. And my personal impression is not only in a professional level, in a personal level nowadays as well. So, I think that it's not that the generations don't understand that the proximal and the digital control, or I think we all realize that it's just how can I teach somebody, like I see Manuela here, hey, Manuela, this is going to be important here. Because if I just tell her that, she's going to go to Google, she's going to check if I'm saying the right thing, and she's going to have more information than I do in 2 seconds. And if I don't present that in a meaningful way, that's it. It's gone. It's completely gone. So, congratulations on your talk. And I think that the issue of communication is one that speaks to our heart, and we have to learn how to communicate better. We all do, I think.
Thank you so much.
Beautiful. Relevant comments, JP. And you can see, Jody, a lot. You're absolutely right. Normally, I check my email during these talks, and today I could not. I did end up putting something in Instagram immediately when you were given the titles and Twitter, because I know that these guys are all pushing me. And then that was it. And then you had me, after the first slide, and I just couldn't stop listening to you. So beautiful. Well, Jody, thank you. We have that plaque that Andres and Carlos and our team are sending you. This was a suggestion, as you know, and demand by our team, because once again, they want to do things that are meaningful to them, and they have you here with all of us listening to you. We're looking forward to having you next year. I love to think about next year when we do the symposium that you guys beautifully put together, to do something in the simulation center. I really do. I want to challenge you and also Robbie Talk and the organizers, so that way we can continue that tradition of the Walter Grande, which is beautiful, and is tying generations and tying principles and being hybrid and being creative. So I know that we have a schedule for you, and we thank you for dedicating your morning also, because this is very important to us to learn from you. You're going to meet the residents, you're going to meet some of the faculty, and I'll wrap it up at the end, I think at 9:15 with you. And you're going to meet the fellows. You're going to meet a lot of people who want to meet you and just want to pick your brains for a little bit. That's it. And we thank you immensely. So Andres, are we in a different link for Jody, for Dr. Leonardo? Is that what the plan is?
Yeah, there's another link, and then everyone will just hop in and out. You just need to stay there, Dr. Leonardo.
Okay, sounds good. Thank you, everyone.
Thanks, everybody. Have a great week.
Thank you.
You got it.